Okay, it is the top of the hour, so let's go ahead and get started. I'd like to welcome everyone and thank you for joining us today. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have the opportunity to submit questions using the chat feature. You are welcome to submit questions at any time during the presentation, but we will wait until the end of the webinar to answer questions submitted. And today's presentation is being recorded and will be posted to the forum website for future reference. I will send an email after this webinar letting you know when when the recording is available. A survey link to an evaluation form will be included in the chat toward the end of the webinar and in a follow-up email that you will receive. We would very much appreciate your feedback. So let's get started. I'd like to introduce Preeti Yearam, Forum President-elect and Chair of our Medical Advisory Council, who has some introductory remarks. Go ahead, Dr. Yearam.
Thank you all for joining and a very good afternoon. So this is lecture number 3 with our Donald Maloney Dialysis Leadership Medical Director series. Dr. Maloney is on the call today. So Dr. Maloney, if you want to turn on your video wave, maybe. Dr. Maloney has been with the forum for a number of years, and he has consistently been a big advocate for education, and he continues to do so in his program at UT. So we thought it was very appropriate to name the series after him. And the first 2 lectures are available in recorded form, as Kelly mentioned, and it would be on the same site where you registered. So please refer back to them and please share the resource with your colleagues, your fellows, and these are great for nurse managers, any kind of dialysis staff. So we hope you find them useful and continue to go back to them. So our lecture number 3 today is going to be on maintaining infection standards in the dialysis unit. And our speaker is Dr. Marc Brazie. He's board certified in internal medicine and nephrology. He currently serves as the Chief Executive Officer of Metropolitan Nephrology Associates in Northern Virginia and Southern Maryland. He serves on the Medical Review Board for ESRD Network 5 and is a member of the Forum's Board of Directors and Medical Advisory Council. He has a lot of experience with value-based care models as well. And we are really excited to have Dr. Brazie talk about infection standards in the dialysis unit.
All right, thank you for that. I appreciate that. I'm going to try to share my screen. Hopefully this works okay. I'm not used to doing this, so let me make sure. I'll share that, and then let me go into slideshow mode. All right, does that seem like it's sharing correctly?
I think you just need to swap the displays.
It's sharing the presenter view?
Yes.
Let me see.
I think you just need to go into display settings and say swap.
Let me go back to this one.
Yeah.
Is that working now?
Yes.
Perfect. All right. So thank you. I appreciate so many people being on the call. I don't know all of the people who were giving lectures as part of the series, but I suspect that a good number of them are in academia. And I may be one of the exceptions in the sense that I'm a private practice nephrologist. So I think I come at some of these things from perhaps a very slightly different lens than some of the other people that will be talking to you all. And I think that can be really helpful actually, because many of the people who are in fellowship training currently, I know, will end up in private practice and may choose that path. So it's nice to be able to hear, I think, sometimes from some slightly different perspectives. I've been a medical director for a dialysis clinic for about 10 to 15 years. And I picked this topic because I think it's one of the more important ones. And so I really wanted to be able to share some insights to these things with you all. All right. So I don't have any disclosures, no conflicts of interest about this topic. I don't really have any significant conflicts of interest in general. So let's talk about kind of why I think this is an important topic and why I wanted to be the one to present on it. I think that obviously infection control is a very important topic from a clinical care perspective. We know that infection is one of the most common causes for death among patients with end-stage kidney disease. It's right up there with cardiovascular disease. And these are a very vulnerable population of patients who are at higher risk for infection to begin with. And we know that having inappropriate infection control practices can also be one of the reasons that you get into trouble a little bit from a dialysis compliance standpoint. And when surveyors come in to do safety surveys of dialysis facilities and quality surveys of dialysis facilities, infection control violations are the most common causes for citations during those inspections. So it's something that it's hard to do it well, it's hard to do it right, but it's really important to do it right. And as a medical director, ensuring compliance with all of the infection control practices of the dialysis facility is one of the responsibilities that is expected of you as a medical director. And I pulled this from the medical director handbook of one of the large dialysis providers where I am a medical director, just to kind of give you a sense from this. This is sort of section 11 under infection control, that as the medical director, they really do expect that you will assume accountability of this oversight of infection control issues, including, making sure that the facility is keeping up with all standards, that all the policies that are internal to the clinic facility are being followed, that all staff are receiving appropriate education and reinforcement on these things, that infection control concerns are brought before the QAI committee and that they're discussed at QAI meetings. So you really are expected to take ownership and accountability for this, and to be a leader in making sure that this is being done right, and in troubleshooting and improving any practices where things are not going right. So these are some of the things that I plan to talk about today. Talk about kind of the background of why I think this infection risk exists among patients with end-stage kidney disease, and kind of the extent of it and the importance of it. Talk about some of the regulatory requirements that dialysis facilities are expected to adhere to regarding infection control. And then we're going to get into several kind of subtopics about very specific aspects of infection control in the dialysis unit, including appropriate hand hygiene, use of PPE, how to properly maintain dialysis accesses and try to prevent infections with dialysis accesses, proper cleaning and disinfecting of equipment and physical surfaces, and then talking about a little bit of medication handling safety in the dialysis unit. I think we tend to talk about these first 4 or 5 topics, or think about these first 4 or 5 topics when we think about infection control. But there's a big piece of it too about trying to prevent infections, is also looking at immunization, and really trying to encourage proper immunization of dialysis patients, and then screening for communicable diseases, and in particular for hepatitis B. And there are very specific kind of screening and isolation requirements for hepatitis B that I think are unique and are worth talking about as a separate topic. So that's what I plan to cover today. Kind of getting at, again, why is this so important? I alluded to this already. Patients on dialysis, we know, have a much higher risk for infection in general. This is for lots of reasons. They have weakened immune systems, but also they are consistently coming to a clinic where they are in close proximity to other ill patients. And they therefore have an increased exposure risk just because of that environment. They also are frequently hospitalized or frequently require surgeries or other medical procedures. So again, they're frequently in these care environments where they might potentially be exposed to others who are ill. We also uniquely are frequently accessing their bloodstream, or if they're doing peritoneal dialysis at home, then there's access to the peritoneal membrane several times per week in order to be able to perform their dialysis. And that in and of itself creates an extra opportunity for very severe, potentially very severe and life-threatening infections. We know one of the best things we can do to decrease infection risk is to try to get rid of central venous catheters. Again, I don't think this is news to anybody that's listening to this talk, but we know that the risk of infection, of dialysis access infection at least, varies by access type, with obviously AV fistulas having the lowest risk of infection and central venous catheters having the highest risk of infection, and AV grafts being somewhere in the middle. So all these things are important to maintain infection control, but the very single best thing you can do for your patients is try to get them a permanent vascular access and reduce the number of CVCs in your clinic as much as possible. bacterial infections are the most common causes of at least dialysis-related infection, and in particular, bloodstream infections. And bloodstream infections occur obviously when bacteria make their way into the blood. These can obviously be very severe and have potentially life-threatening consequences. Patients can develop very severe sepsis, and the statistics are up to 1 in every 4 bloodstream infections results in death. So, again, this is a very vulnerable population, and we really, really want to try to decrease the risk of bacterial bloodstream infections. In addition to the health outcomes for the patient, these have very high associated treatment costs. Every time a patient goes into the hospital with a bloodstream infection, that costs the healthcare system quite a bit of money. It can lead to other downstream health problems like endocarditis or osteomyelitis that also may require more prolonged treatment or more significant duration, and it increases morbidity in addition to mortality. And because these require the use of antibiotics, if you're having frequent bloodstream infections in your facility, that's going to lead to increased risk for secondary infections like C. diff, or potentially promote antibiotic resistance within your clinic. So these are all the reasons that we really want to try to prevent bacterial infections as much as possible. Viral infections obviously are common too, and that includes bloodborne infection. And the one that we really pay the most attention to in dialysis, I've already mentioned, is hepatitis B, but also a lot of viral respiratory infections are very common in the dialysis setting, including flu and coronavirus, not just COVID-19, but all coronavirus, other rhinoviruses and adenovirus and common cold viruses as well. All right, hospitalizations for infections continue to rise. So even though we know that this is a problem, this is something that, to be honest, we are not super good at. Hospitalizations for infection have increased almost a little over 40% in the last 30 years or so, despite the fact that overall hospitalization rates are down and total number of hospital days are down. So this doesn't just reflect an increase in hospitalizations overall. This is actually showing that infection is becoming a more common reason for hospitalization in general. And at least in the healthcare setting, there are estimates that anywhere between 50 and 70% of healthcare associated infections are potentially preventable. So again, this is an area where it's really important because not only do these infections carry high risk and high cost and high morbidity and high mortality, but a good number of them, perhaps even a majority of them, are potentially preventable with appropriate infection control practices. And of the things that are preventable, the highest risk is contaminated healthcare worker hands. We are the greatest risk to our patients. They are much more likely to catch something from you or from a dialysis nurse or a dialysis technician than they are from another patient in the facility. And so I think that's really important to take that responsibility very seriously. All right. From a regulatory standpoint, again, I alluded to this a little bit, but I wanted to dive into this a little bit more because this is something that I didn't learn anything about in fellowship and I didn't know much about. But obviously, most of us know that dialysis, end-stage kidney disease care is covered under Medicare for all adults. And this started in the 1970s with expansion of Medicare. But because that is now something which is a covered benefit under Medicare, kidney disease is an area where there's quite a bit of government regulation. And the government has set certain expectations and certain requirements for what must be provided in the dialysis setting. And these regulations have been modified several times over the years. They were modified in 2005 and they were modified again in 2018. And all of these regulations fall into what's called the 42 Code of Federal Regulations, or CFR, but you will more commonly hear people in the dialysis world refer to this as the conditions for coverage. That's usually the term that we use. And this is basically a list of all of the requirements that CMS has, the Centers for Medicare and Medicaid, for that dialysis facilities must adhere to. And they contract with survey agencies to periodically perform inspection surveys of dialysis clinics to make sure that they are following all of these required conditions. And any deviations from any of these requirements can result in citations for the dialysis clinic. And those citations have several levels of severity, ranging from a standard citation, which is something that's not too serious, to a conditional citation, which is certainly more serious, to something called an immediate jeopardy citation, where immediate jeopardy means that facility is literally in immediate risk of potentially being shut down if they can't immediately rectify some of the concerns that were identified. I mentioned already that infection control issues or violations in infection control practices are the most common cause for citations in general. It's also the most common cause for immediate jeopardy citations. So again, it's an area that the government takes very seriously, as they should, and therefore we need to take very seriously in our responsibility as medical directors. So it's really important that we adhere to these infection control standards at all times. All right, so what can we do? I wanted to kind of talk about, just general basics about how infections spread, which is again, everybody understands this, but I didn't always think about things this way, and use this as kind of a springboard to talk about how in this process then can we target each of these risks to try and reduce the infection risk. So basically, all infectious pathogens require four things to be able to grow and thrive and spread. They require a reservoir. And in the healthcare space, there's really sort of two reservoirs that we need to think about. One is the human body itself, right? We all have bacteria that lives on our skin, in our gut, in our lungs, our mouths. It can, some viruses in particular can live in the blood as well. And then the environment can also be a reservoir for infection, particularly wet surfaces, water or wet surfaces. Some bacteria grow really well in water. Pseudomonas is often a waterborne pathogen, right? But also dry surfaces, dirt and dust, which can trap infectious material and can make it harder to clean and disinfect surfaces. And then the actual surfaces of medical devices and equipment themselves. In addition to a reservoir, they require a pathway. So they need some way to be transmitted from one person to another. This usually involves either inhalation, particularly in the setting of respiratory viruses, but very frequently touch, right? So skin to skin contact, your hand touches a contaminated surface and then touches another individual and infection gets passed that way. Less commonly with splashes or sprays, but we do need to worry about that, particularly with bloodborne pathogens. You worry about, blood splatter or blood sprays being a potential source for infection. The third thing they need is they need a person to infect. But I like to point out that this isn't just our patients that we're talking about, right? Healthcare workers can be the person that gets infected, and then they can then act as the reservoir to infect someone else, or even visitors to the facility, visitors to the clinic could be someone that could act as a carrier for infection. And then lastly, typically we have pretty good barriers to try to defend against these things. And so infection typically occurs when the pathogen finds a way around our body's natural defenses. And I have the picture here of, someone starting an IV cannula because, we are performing activities on our patients that by their nature disrupt the body's natural defenses, right? We are penetrating the skin. We have a latex catheter surgically implanted in the peritoneum. We are artificially violating the body's natural defenses to infection and creating a riskier situation for our patients. So with this kind of framework in mind, I think there's sort of two questions we can ask ourselves when we're trying to figure out what can we do about infection control. The first is, okay, the task that I'm about to perform, whatever's about to happen for this individual, what are some of the infectious risks associated with this task in and of itself? And with that in mind, what steps can I take to try and mitigate those risks? Again, considering, reservoirs and how can we reduce where bacteria live and thrive, thinking about modes of transmission, how can we, get rid of some of those pathways of transmissions, thinking about where we are disrupting natural barriers to infection, what can we do to try to minimize the impact of that? And so with that in mind, we're going to go through kind of what some of these good infection control practices in a dialysis facility are and kind of how they help to prevent some of the spread of pathogens. All right, this is just a couple other things. Shameless plug. This comes directly from the forum's medical director toolkit. I'm sure you guys have been told by others about all of the different toolkits that the forum has put together. If you've never looked at them, you should definitely go check out the site. There's some fantastic information in there. But this is, I pulled a couple of these tables directly from the medical director toolkit, talking about infection control specifically for the medical director. So the CDC published recommendations for infection control practices for hemodialysis facilities. And CMS incorporated these recommendations into the conditions for coverage. So these are some of the expectations that CMS now has that dialysis facilities should be doing all of these things. So you need to have infection control precautions in place that have been specifically designed to help prevent transmission of infectious diseases. We are required to perform routine serologic testing for hepatitis B and C. The recommendation for the CDC was to do both. CMS does not require regular testing for hepatitis C. They do require it for hepatitis B, but it's encouraged to check periodically for hepatitis C as well. We need to be making sure that we're at least offering vaccination for all patients who are susceptible to hepatitis B, and that we are isolating patients who test positive for hepatitis B surface antigen. You need to have a process of surveillance for infections and other adverse events, and we need to have some process for providing ongoing infection control training and education to your staff. So these are some of the things that CMS says that we should be doing, and CDC says that we should be doing. And in addition, they published 9 of what they call effective interventions that have been proven to help reduce infectious risks. So using monthly surveillance and feedback. So simply monitoring how your facility is doing from an infectious disease standpoint, and keeping an eye on that in and of itself helps with infection reduction, to really shine a flashlight on this and focus a lens on this. Doing surveillance of hand hygiene. It's recommended that dialysis facilities do kind of their own internal audits on a monthly basis, to just go out on the floor and watch your staff and see how effectively they are actually performing their hand hygiene. Are they doing what they're supposed to do? Similarly, observing catheter care and vascular access, and are they following all the proper procedures for accessing a central venous catheter or cannulating a vascular access? Patient education and engagement, not just about routine infectious concerns, but specifically around vaccination and immunization and things like that. Obviously, having a robust staff education system and some way of testing those competencies. I already mentioned catheter reduction. To me, everything infectious disease starts with catheter reduction. Specifically, they recommend using chlorhexidine for skin antisepsis prior to catheter cannulation insertion. That's found to be a little bit better than other antiseptic topical solutions. Rubbing and cleaning the catheter hub after you remove the cap from the catheter and before you make connections to the dialysis tubing. Scrubbing that hub is a practice that's been shown to reduce infections. And then using dressings that have some antibacterial properties. So these are just, again, some of the ideas of things that can hopefully be built into the dialysis facility to help reduce the risk for infection. All right, so now we're going to launch into kind of that last part that I put on my objectives of kind of the 6 or 7 subcategories of specific infection control strategies that we should all be doing in the dialysis unit. None of this should be news to you all. I mean, hopefully all of this is things that's pretty familiar, but it's nice, I think, to kind of go through it in a systematic way. So everything starts and ends with hand hygiene. As I mentioned, this is already, this is the #1 cause of potentially preventable healthcare associated infections. And so simply consistently following hand hygiene practices is the most effective way to help stop the spread of germs. It is, despite the fact that we know this, despite the fact that hospitals pay attention to this and dialysis facilities pay attention to this, when you look at blind audits, when people just go in and they just observe what happens in the dialysis facility, observe what happens in the hospital setting, this is performed correctly and consistently only about half the time by healthcare workers. So we really do need to do a better job of this, and it is something that I hope that anyone as a medical director would try and set a good example of themselves, but also police and monitor whenever they observe someone else not doing this well, right? So you have 2 options for hand hygiene. Obviously, there's hand washing, or there's using some kind of an antimicrobial, antiseptic, alcohol-based hand sanitizer. You can do either of these most of the time, but you must wash with soap and water anytime your hands or your gloves are visibly contaminated with blood or other bodily fluids, or anytime before eating or after using the restroom. Those are the 3 points where you should really, not just should, but where you really must choose soap and water over an alcohol-based hand sanitizer. Otherwise, if you're just changing gloves, if you're just going from station to station, but your hands are otherwise clean, there's no visible, contamination, you can sanitize with hand sanitizer. You should wash your hands. It should take you about 40 to 60 seconds to do it right. Whereas cleaning with the alcohol-based sanitizer usually doesn't take quite as long, about 20 to 30 seconds. But again, you really want to make sure you're getting every surface of the hand. And there's, CDC has a video online. I thought about putting it in here. I opted not to because it's a little bit obnoxious. But watching them, really go through the whole regimented way of washing your hands properly for a full 60 seconds. But take your time, do it right. It's important. When do you need to be washing your hands or performing hand hygiene. Again, these rules are the same in the dialysis unit as they are in the hospital setting when you're in the inpatient setting. Anytime before you touch a patient or after you touch a patient, you should sanitize your hands. Anytime before you're performing an aseptic procedure, obviously you need to start with clean hands for an aseptic procedure. Anytime you come in contact with any potentially infectious material like blood, body fluids, or contaminated surfaces, obviously before performing any major procedures. When moving from a dirty task to a clean task, this is actually a really important thing I think people don't think about. And the example that I will give you, I may actually have it written somewhere else in my presentation, but dialysis patient with a central venous catheter comes in and the dialysis tech is getting ready to connect them to the machine. The first thing that they do is they remove the old dressing. Well, the old dressing is dirty. That dressing has been on the catheter, since the last time that they had dialysis. That's a dirty procedure. So after you remove the old dressing and you've done whatever else you've done to kind of prep the area, before you move on to removing the caps and scrubbing the hub and making your connections, you need to change your gloves and perform hand hygiene because you're going from a dirty task to a clean task. You don't want to do all of that with the same pair of gloves, right? After contact with inanimate objects, that kind of goes with the fact that any surface can potentially be contaminated. And then obviously before you put on gloves, you want to start with clean hands, and after you remove gloves, you should perform hand hygiene again. So again, all that's review, but it's just good to sort of see it all written out there. PPE is really huge in the dialysis facility. Again, we are performing a procedure where there is potential for exposure to blood in particular. Hopefully not other body fluids, but people get ill. Sometimes there's vomiting. I mean, things can happen. So you want to make sure that you're wearing appropriate protective equipment to avoid yourself being contaminated. It's important to know that PPE protects you, the healthcare worker. It doesn't protect the patient. You're not putting on PPE to protect them from you. You're putting on PPE so that you don't become contaminated from the patient. And this can include anything, that helps to protect against infection. In the dialysis facility, we're really talking primarily about gowns, gloves, face masks, and face shields. But PPE obviously can be expanded to include more than that. And what is recommended PPE depends on obviously the clinical setting and the situation. Any time that your PPE becomes visibly soiled with blood or body fluids, and by the way, spent dialysate, dialysis effluent counts as body fluid, even though it's not technically a body fluid. It needs to be considered a body fluid. But also secretions or other excretions, you need to change your PPE and go get clean, fresh PPE and put on new PPE. I went through each of these in a little bit more detail about how to kind of use them properly and when to use them. So gowns, I see people put gowns on the wrong way a lot. They need to be worn correctly, which means that the openings at the back, the sleeves come down to the wrists. If you've got a gown, but you've got your sleeves pushed up to your elbows, you're not wearing your gown correctly. And it needs to be tied. If you don't take the time to tie the, strap around the waist, then your gown really isn't being put on properly. So take the time to actually put it on correctly and put it on fully. And it needs to be worn anytime you could be exposed to any kind of bodily fluid. So droplets, blood splatters, bodily fluids. In the dialysis unit specifically, this means during initiation or takeoff procedures. Okay, even as an attending medical provider, if you are on the dialysis unit during change of shift, when patients are being put on or taken off from machines, you need to have a gown on. Okay, I don't know that all medical providers realize that. Anytime the access is being adjusted, so the patient's on the machine and you're getting a high venous pressure, venous access pressure, and the PCT comes over to try to manipulate the needle a little bit to see if they can just reposition it slightly or reposition it differently to help with that. They need to be wearing full PPE because they're manipulating that needle, manipulating the access. Anytime a nurse is administering medication, they need to be wearing full PPE. And while cleaning or disinfecting surfaces. So a lot of this is going to occur around change of shifts when a patient's being taken off, the dialysis setup is being washed and disinfected prior to the next patient being started. That's really when the sort of full PPE is required. You need to take off your gown anytime you leave the treatment floor or the home training area. Okay, so don't wear your gown into the break room in the back while you're eating lunch. Take it off and leave it on the floor. If it's clean, if it hasn't been soiled and it's otherwise clean, it is okay to take your gown off and hang it on a wall rack or something and reuse the same gown when you come back onto the treatment floor. But it does need to be taken off before you leave the treatment floor. And then I already mentioned this, but if it becomes soiled, or then you need to go ahead and throw it away and discard it and get a new one. Or if it's showing signs of wear, if you've got your strap tied and it's starting to tear there or something like that, go ahead and get a new gown that's not showing signs of wear and tear. As a reminder, again, always perform hand hygiene, wash your hands after you remove your PPE. Face protection, it's really kind of similar rules to gowns. We're really talking about both a face mask and a face shield. Those are the two types of face protection. Surgical masks obviously only protect your mouth and your nose, whereas a face shield also protects your eyes. And so anytime there's the opportunity for splatter or spraying of bodily fluids or blood, you need to have a full face shield, not just a mask. So that's the same moments in time during dialysis initiation or takeoff, during access adjustments, medication administration, or cleaning and disinfecting services. So again, I want you guys to know all of this because most of you are not going to be dialysis technicians, but I want you to be able to observe the staff and the facilities that you go to make sure that they are actually following these guidelines. There are other things like protective eyewear where it has the sort of full side shields. I don't really see those being used. Like these are like goggles. You don't really see those being used much. You would have to pair that with a face mask. And then prescription glasses, it's just worth noting that those really are not considered appropriate eyewear by OSHA. So you can get away with it in your, middle school, high school shop class. You cannot get away with it in the dialysis facility. It is not appropriate eyewear for this purpose. So gloves. Gloves need to be used in even more settings than gowns and face masks. Gowns and face masks primarily, again, that's during initiation, takeoff, and cleaning and disinfecting primarily, change of shift moments. Gloves need to be used anytime you have any interaction with the patient or the patient's equipment at the dialysis station. You should never be touching the dialysis chair, touching the dialysis machine, touching anything at the dialysis station with your bare hands. Okay, you need to be wearing gloves anytime you're doing that. And gloves must be changed every time you move from one patient to another or from one patient station to another. Okay, so two different machines are alarming and someone needs to go address those two alarms. They need to perform hand hygiene, put on a pair of gloves, address the issue at one station, take those gloves off, perform hand hygiene again, put on a new pair of gloves, and then go address the alarm and the need at the second dialysis station. This is probably the area where the most violations occur in the dialysis setting because techs want to just quickly silence that alarm, quickly do something. And so you'll see them go from one machine to the next without changing their gloves. Or you'll see the finger glove. They'll put one finger through a glove to touch the machine through that one finger. That is a violation of infection control practices. You have to have the gloves fully on your hands. You have to have performed hand hygiene before and after, right? And then I mentioned this. This is my example. Here's where I have it of when moving, even when you're caring for the same patient, if you're moving from a dirty activity to a clean activity, you need to change your gloves and perform hand hygiene in between those two activities. Okay, gloves do not replace the need for hand hygiene. Okay, you still have to perform hand hygiene when you take your gloves off. Even though you're wearing gloves and hopefully that protected your hands from becoming contaminated, you still need to perform hand hygiene again when you take the gloves off. All right, let's talk about some specific infection control practices for dialysis accesses, because this is a really big risk, right? We already mentioned this. This is one of the moments or one of the situations which creates the most vulnerability for our patients, right? Is that we are accessing either a fistula or a graft or a central venous catheter every time they come in for dialysis, and you have direct access to the bloodstream, right? So we really need to make sure that we're using proper aseptic technique to avoid bloodstream contamination during access and deaccessing of vascular access. So what is aseptic technique? It's just a process of trying to do things in a sterile way, right? And it's essential anytime you are cannulating or removing needles. We think about the cannulation part a lot. I don't think we always think about needing to remove needles and deaccess the access in an aseptic way as well. Okay, here are some things you can do to help. All patients with a graft or a fistula should be asked to wash their access prior to cannulation. This is something, I'll be honest, very few dialysis patients do, and very few dialysis providers or dialysis staff are terribly good at requesting or recommending. But it really helps. I mean, if they start with clean skin by washing the area over their access prior to cannulation, that's really going to help reduce the risk for bacterial infections. Then the skin still needs to be cleaned with some kind of a sanitizing product prior to cannulation. This is usually done with either alcohol or chlorhexidine. The key part to this is that once the site's cleaned, you can't touch it afterwards, right? This is a mistake I see a lot too. Um, Dialysis technicians need to know where the graft is or where the fistula is. They need to feel the thrill. They need to feel where they're going to cannulate, but they need to do any of that touching of where they want to cannulate prior to disinfecting the skin. I've seen them disinfect the skin and then take their gloved hands. They don't have sterile gloves. They just have normal latex gloves and start feeling the catheter to feel, where that thrill is the fistula to feel where that thrill is the best. Well, you've just touched your sterile skin surface with a non-sterile glove and you've just contaminated the skin again. So you need to clean it and then don't touch it again after you clean it. You need to use a circular motion. So start in the middle and then kind of make slightly larger circles as you work your way out. You want to provide some gentle friction. I mean, you want to put a little bit of pressure there. So you're kind of lightly scrubbing the skin. You're not just wiping it. You're actually providing a little bit of friction and lightly scrubbing it. And then you need to allow the disinfectant to air dry. Okay. People, I see this when people, draw labs, even at like LabCorp request, they like wipe your skin down with an alcohol wipe and then take a cotton swab and wipe it off. It has its antiseptic effects while it's drying. So you need to let the disinfectant air dry. Don't blow on it. Don't use a fan. Don't wave your hand over it. Don't do anything else. Try to speed up the drying time. Be patient. Let the disinfectant do its work. And like I said, don't touch the site again. The proper way to do this, because with a fistula or graft, you're cannulating two sites, is to sanitize one site and go ahead and cannulate in that location, and then sanitize the second site and go ahead and cannulate in the second location. Don't try to sanitize the entire arm before you do either cannulation and then try to cannulate both sites back to back. When you're removing needles, there's not as much involved, but you still want to make sure that you're performing hand hygiene and that you're using clean gloves. And then if the patient is going to be holding pressure over their own access, make sure that the patient is also wearing a glove. And then once hemostasis is achieved and there's no more bleeding, make sure you put on a nice, fresh, clean, dry dressing with tape, and don't wrap the tape, all the way around the arm, just kind of, over the skin lightly. What about CVCs? CVCs, I mentioned, are even higher risk for infections. And I've got my little picture here of a CVC coming out of someone's chest. These are even higher risk for infection because unlike a fistula or a graft, where you really have that one moment in time where you're puncturing the skin, where there's the risk for introducing bacteria, but then at least between treatments, there's nothing, there's no direct pathway. With a CVC, you've got this catheter protruding through the skin and into the central venous circulation at all times, right? And so germs present on the skin can get in through the exit site and they can migrate down the catheter tunnel, and they can either form a tunnel infection, which is not so severe, where just the skin under the tunnel, within the tunnel is infected, or they can make it all the way into the bloodstream and cause a bacteremia. So two areas of primary focus. One is the exit site. And so we should be providing good exit site care with every dialysis treatment. And again, here's the proper steps for that. The nurse or the tech should place an underpad under the catheter limbs, so kind of like a sterile, not sterile, but a clean pad underneath where the catheter is. Then make sure they're masked, make sure the patient is masked so that no oral bacteria contaminate the catheter site during cannulation or decannulation. If you're ever around and you're doing your rounds while someone's got a catheter that's being accessed, put a mask on yourself, put a face mask on. Make sure you have clean gloves, remove the old dressing, check the dressing for any signs of infection, visually inspect the exit site area for any signs of infection. If any signs of infection are noted, then a charge nurse or a provider should be notified. Then again, because removing the dressing is a dirty task and you're about to move on to a clean task, you then want to discard that dressing, remove those old gloves, perform hand hygiene, put on new clean gloves, and then begin to clean the exit site with a sterile cleaning solution and applying a new sterile dressing to the site. The other area of CVCs that are high risk for infection is the hubs, right? So the hubs are, the ends of the catheter that are actually being connected to the blood lines to be able to perform dialysis. And so this is very important that you follow aseptic technique again when taking the caps off of those hubs. And then between taking the cap off of the hub and connecting either a syringe or the blood lines, you want to scrub that hub with an antiseptic solution as well to make sure that it's sterile. That's one of those infection control practices that's been shown to really make a big difference. Aseptic technique, I kind of already alluded to. It's just this sort of set of practices where you do these things in a particular way to prevent the introduction of germs. It involves following very strict rules that have been established. And the important thing is that once you're beginning this task that requires aseptic technique, you have to be really thoughtful and mindful of not doing anything to then contaminate your hands, the equipment that you're using, or kind of other materials involved in that task. All right, let's talk about cleaning and disinfection because this is an area that I think gets glossed over a lot of times. So one thing is just think about the setup of the dialysis unit, right? You want the environment itself to be set up and planned out in a way to try and prevent cross-contamination of dirty things contaminating clean things, okay? So what are some examples of this? You should never take something from a patient's dialysis station back to a clean area or to another patient station without it being disinfected first. What does this mean? This means if you're using a glucometer, that glucometer has to be disinfected between patients, right? This means that, if you, the provider, use your stethoscope to listen to a patient's heart and lungs, you need to sanitize your stethoscope before you bring it to the next patient and use it again on the next patient. This is another very common area of violation where, nursing staff will use sort of a common piece of equipment that they'll go and use it for one patient, and then they'll bring it back to a clean area, or they'll bring it directly to another patient station without disinfecting it in between. And that's a violation. When possible, if there are items that can't be, sterilized, like you can't really sterilize a roll of tape, you can't disinfect a roll of tape. You should try to make those single-use items that are restricted to a single patient or are discarded so that they're not being shared among multiple patients. Within the clinic itself, clean areas always need to be separated from dirty areas. Okay, so you should have a clean sink. You should have a dirty sink. That's really important. The medication prep area where nurses are prepping medications needs to be a clean area, obviously. If you have that common equipment like a glucometer and you've gone and you've used it for one patient, you should return it to a dirty area. And then once it's been cleaned and appropriately sanitized, it gets moved to the clean area so that people know if they need it again and it's in the clean area that it has already been cleaned and sanitized and disinfected and it's ready to be used again. And then obviously just setting up the clinic where convenient access to the materials that you need, that there's plenty of gloves, plenty of sinks that are easy to get to. Most dialysis clinics have hand sanitizer right there at each dialysis station, right? So it's very easy to access the hand sanitizer. The more that you can create an environment that makes it easier for your staff to follow these rules, the more likely that they are to actually follow good hand hygiene and do these things. All right. And then complete cleaning and disinfecting of all the equipment and environmental surfaces is also important. So we talked about, setting up your environment in a good way, but then also performing proper cleaning and disinfection is really important. And I wanted to just kind of define the definition because these are not the same exact thing, even though I think these words are sometimes used interchangeably. Cleaning is where you remove dirt and germs from the surface. So you're just kind of actually removing things from the surface. And cleaning is important because if there's dirt, if there's grime, if there's things built up on the surface, it's much easier for bacteria and infectious pathogens to get trapped there on the surface. But cleaning alone doesn't do anything to kill germs. It just removes them. Disinfection is the process of using a chemical that actually will kill germs present on the surface. And so there's sort of two ways that you can approach cleaning and disinfection. Sometimes these can be performed together as one step. There are some products that will simultaneously clean, dirt and grime off and disinfect at the same time. Or it can be done as two steps. And if it's done as two steps, it's important that cleaning always occurs before disinfection. Because again, that disinfecting solution is not going to have a chance to really fully get to the surface to kill all of the germs that are there if there's still dirt or grime on top of it. Disinfection of the dialysis stations is typically performed with a bleach solution. It's usually a 1 to 100 diluted bleach solution. And this includes the entire dialysis station. So it's not just the dialysis machine itself. The chair also has to be disinfected. And both the dialysis machine and the chair have to be disinfected between every treatment. So if you're running 3 shifts, in a day, you have to disinfect between your first shift and your second shift and disinfect again between your second shift and your third shift. And then the wall and the wall box kind of behind the dialysis unit where you might have your central acid bath, or if you're still using a central bicarbonate loop, where you might have your central bicarbonate loop coming in, that needs to be disinfected just once at the end of the day, unless there is any obvious blood spatter or there's a spill. Then it needs to be disinfected right away. One thing we don't think about is the blood clamps, the actual little plastic clamps that go on the blood lines. Those clamps are reusable and they are reused, but those must be disinfected between every treatment as well. And so those need to go into the 1 to 100 bleach solution and soak in the bleach solution to be disinfected. And they need to be put in that solution in an open position. The clamp can't be clamped shut. It needs to be in the open position when it goes into the bucket to be disinfected. And then again, same rule about this as cleaning the dialysis access. All the surfaces need to be allowed to completely dry before more clean materials can be brought to that dialysis station to be set up for the next patient. The biggest mistake I see made with cleaning and disinfection in the dialysis unit is that people really want to do that changeover of that change of shifts as quickly as possible. And sometimes they will start to clean and disinfect the dialysis machine while the patient is still holding pressure over their access site. If the patient is still sitting in the chair, you cannot start cleaning and disinfecting their dialysis machine. You need to wait until that patient has left the unit, and then you can disinfect both the dialysis machine and the chair together. So you can't start while the patient's still there holding pressure on their access. All right, injection safety is really brief and quick, but we do use parenteral medications in the dialysis unit with some regularity. And so this is just a reminder that that's another potential moment where infection could be introduced if those medications are not being administered properly. So this means that making sure that your nursing staff are taking proper precautions for storing, preparing, administering, and discarding of medications. They should never be carrying medications in their pockets. So don't, draw up a medication and then have it, stick it in a pocket. You shouldn't use carts that are taken from station to station for multiple patients because, again, everything needs to be disinfected in between patients. Obviously, nurses should perform hand hygiene before preparing medications, but also before administering them. They need to make sure that they scrub the injection port where the medication is actually going to be going into the blood lines to make sure that no bacteria is introduced during the actual injection of the medication itself. Make sure that the medication is being administered correctly in the correct location, and then that everything is being discarded appropriately at the end. Unused medication that have gone to a patient station cannot come back to a common area or a medication prep area. Again, once it's been taken to the dialysis station, it's considered dirty. It cannot come back to a clean area. All right, let's talk a little bit about immunization and screening for infectious diseases, and then I have a couple of slides to talk about hepatitis B, and then we'll wrap up and leave time for some questions at the end. Screening and immunization, all patients must be screened periodically for hepatitis B. I would encourage you to screen patients periodically for hepatitis C as well. And any patient that screens positive, newly screens positive, meaning that they're a new conversion, should trigger a root cause analysis. You should go back and try to figure out, how did that person develop hepatitis B or hepatitis C? Did it occur in the dialysis facility? Is it possible that it occurred somewhere else? If it occurred in the dialysis facility, what happened? What broke down with your infection control process that happened? Hepatitis B vaccination is recommended for all dialysis patients and all dialysis unit employees. So you should really strongly encourage this among all of your patients, encourage it among all of the staff. Most dialysis clinics, they vary, dialysis providers, about whether they mandate some of these things or just strongly encourage them. If you have any say in it, my recommendation is if you can get away with it, you should try to mandate these things for staff as much as possible. Medical directors have to be familiar with isolation protocols for hepatitis B. Not correctly isolating hepatitis B patients and doing appropriate screening and surveillance for hepatitis B is probably the #1 risk for an immediate jeopardy citation, okay? Because that's a big, big deal if we are allowing hepatitis B to be transmitted because of inappropriate practices in the clinic. Patients need to be screened at least once for TB. Most dialysis providers, I think, tend to do this annually, but they have to be screened at least once at admission. And then all dialysis patients should be strongly encouraged to receive the flu vaccine. My practice at my facility, and what I would encourage everybody to do is, as the medical director, that's one of your responsibilities, even if it's not your patient. This is within your purview as the medical director to say, I'd like a list of every patient who's declined to the flu vaccine this year, and go around in the clinic and just talk to them all and see if you can provide any additional education, any additional resources, any additional encouragement to maybe get them to reconsider that. right? Employees should also be encouraged to be vaccinated against influenza. I've been trying to push to make this a mandate, but the dialysis providers tend to be more flexible than I would be. Pneumonia vaccination should also be recommended for dialysis patients. So these are the really big ones. We really try to encourage hepatitis B, flu, and pneumonia vaccination. Dialysis clinics are tracked on those things, and that is something that is reported on in the monthly QAI meetings. And you should be involved in that process and really trying to encourage that to happen. All right, hepatitis B. Why do we care so much about hepatitis B in the nephrology space and in the dialysis space? It's because it is highly infectious, much, much more infectious than other bloodborne pathogens. This is just data based on a single needle stick incident, but the risk of acquiring hepatitis B from a needle stick from a hepatitis B positive patient is 30%. And it's nearly a 1 in 3 risk of developing hepatitis B, as compared to only 3% for hepatitis C and around 0.3% for HIV. So it is much, much more infectious and contagious than other bloodborne pathogens. And it can live on surfaces for up to 7 days or longer. So, we have to be really, really careful with our hepatitis B positive patients that we are not subjecting any other vulnerable patients or susceptible patients to that risk. Okay. This is why it requires special protocols, both for testing and isolation of patients. And this is why all patients actually require hepatitis B within 30 days prior to being admitted in a dialysis facility. The only 2 tests that are actually required for admission are a surface antigen and a core antibody, but I would recommend that you check all 3, that you also check the surface antibodies. And this little table here is overly simplified. There will be some dialysis patients that don't fit neatly into one of these 5 categories, but this is kind of the traditional teaching on hepatitis B, right? That if all 3 are negative, it means that you are negative for hepatitis B, but you're not immune either, right? So we call that someone who is susceptible. That is someone who is at risk for potentially acquiring hepatitis B should they be exposed to it. Okay, and we have to treat susceptible patients a little bit different in the dialysis facility. Right? If they have surface antibodies, but negative core antibodies and no antigen, that's someone that's probably been previously vaccinated and is therefore immune. And the reason that we know they're vaccinated and didn't have a natural immunity is because they don't have any core antibodies, right? If someone has both surface antibodies and core antibodies, but they're surface antigen negative, that suggests someone who is also immune, but they're immune from a prior infection. So that's a previously infected individual who cleared that infection, did not develop a chronic infection with hepatitis B. So they're now immune and they have both antibodies are positive. Someone who has a positive surface antigen and a positive core antibody, but no surface antibodies, this is the classic presentation of someone with an active ongoing hepatitis B infection. This is your chronically infected individual that requires isolation and requires treatment in an isolation environment. The last one I have on here is this one that can be tricky, where you have core antibodies, but you don't have surface antigen or surface antibodies. And I say unknown because this can really represent one of 2 things. This can either represent somebody who has an active infection, but they're in what we call the window phase, right? Where they have core antibodies and the surface antigens going away, but they have not yet developed the protective surface antibodies. This is someone that you would still, I think, consider an active infection and may need to isolate for that. The other possibility is this is someone who was previously infected. They would fit under this past infection immune category. But then because of the energy that you get with end-stage kidney disease, their surface antibody titers have just waned over time, so that now their surface antibodies have dropped below detectable levels, but they actually are still potentially immune. If you get this one, that's where you're going to do some additional testing. You may do, a core antibody, break it down to see if it's IgM versus IgG. You may get a PCR, obviously, to look for actual hepatitis B in the blood directly. But most of the patients are going to fall into one of these 4 categories. Why is this important? Any patient with an active infection requires isolation in an isolation room. The newest version of the conditions of coverage actually has a mandate that all newly built dialysis facilities or any dialysis facility that goes through an expansion must include an isolation room as part of that construction. You may still encounter older dialysis facilities that were built before these new standards were in place that don't have an isolation room, but all newer dialysis facilities or newly expanded, renovated facilities have to include an isolation room in them. And an isolation room has to be equipped with everything needed to perform dialysis for that patient. It has to stay in that room. It never leaves that room. Okay. They have their own centrifuge. You have to have all of your own, glucometer, blood pressure equipment. Everything that you could possibly need has to live in that room. It has to be labeled. That's another very common reason for citations is that equipment in the isolation room is not appropriately labeled. And it even has to have its own cleaning supplies. You have to have separate janitorial equipment and a separate, bucket for your bleach solution, everything that is only used for the isolation room and is not used on any of the other machines in the facility. So it's really important that this is being followed correctly. Last thing I'll say about this is if you do not know the hepatitis status of a patient, please don't ever treat them in the isolation room because you are knowingly exposing that patient to hepatitis B by doing that. And if you don't know their status and they're susceptible, that is super, super risky. So the way that those patients have to be treated, if for some reason you don't know their status, that's an emergency, they showed up, whatever, um, you have to treat them as though they have an active infection in terms of PPE and nursing techniques. So put them at the end of the loop in a separate area of the clinic, and the nurse that's caring for them needs to use PPE only for that patient, et cetera, as though they're infected. But you should not treat them in the isolation room. And you should treat them with what we call a buffer zone. So the reason I went through this criteria, let me go back one slide, of susceptible versus immune versus an active infection, is only patients with immunity to hepatitis B can be positioned in stations near your isolation room. Any patient who's susceptible needs to be positioned in a dialysis station that's further away from the isolation room. We call that the buffer zone. So immune patients can be the only patients that treat within that buffer zone. And so if you have a patient where you don't know the hepatitis status, you want to create a buffer zone, a second buffer zone around that patient as well. So put them at the end of the loop with immune patients around them so that they're separated in space and distance from your susceptible patients. But don't put them in the isolation room. I think that's super important. And that is my last slide. I have talked a lot. And at this point, I know we had a couple of questions that came up in the chat, and we can also kind of open it up for additional questions as well.
Yeah, thanks, Mark. That was an excellent and very comprehensive overview of infection control. Yeah, so we do have a few questions. I think the first question was when you mentioned wearing PPE during medication delivery, does that include oral medications?
Yeah, that does not include oral medications. That includes specifically when you're doing injection medications, because again, that's where you're actually accessing those medication ports on the blood lines and going to be actually administering parenteral medications.
And what do you think about covering your stethoscope with a latex glove rather than disinfecting it?
I'm not a huge fan of that, to be honest. I actually don't think it obviates the need to disinfect your stethoscope, and it makes it harder to hear what you're listening for. So you're better off to just use your stethoscope and then disinfecting it. You do not have to go get a 1 to 100 bleach solution to disinfect your stethoscope. It is acceptable to use hand sanitizer to disinfect your stethoscope. So what I do is I just sanitize my hands and then get a second squirt of the hand sanitizer and use that to rub, the bell and the drum and the tubing of my stethoscope before moving on to the next patient. So
Please feel free to add any questions to the chat. So while we are waiting, I have a question to Mark. So I know you showed the slide where it said 40 to 60 seconds of hand washing and using antimicrobial. But I know when we were going through COVID, the 20-second rule was all over, right? So
right.
how does this differ from that? And
Yeah, I
then the
mean,
antimicrobial, I don't think necessarily antimicrobial, but any soap is what is
yeah,
right.
I think you're right. So I pulled that straight from the sort of the CDC's website. They have a little thing, like I said, it's like a video on how to properly wash your hands, where they say, rub it into a lather on your palms, and then do like the palm of one hand against the back of the other, and then switch, and then do your hands back and forth like that. So they have this whole kind of thing, and they say it should take 40 to 60 seconds to do it properly. Um, I was taught, sort of 30 to 40 seconds. I was taught to sing, row, row, row your boat twice, or, sing the alphabet song in your head twice, or,
Yes.
pick something like that that you can kind of time yourself with. I think the point is probably less about how much time you spend doing it and more about, um, doing it in an intentional and a focused way where you're paying attention to what you're doing. Because I think we wash our hands so often that we kind of don't think about it and we tend to do a sloppy job with it, right? So if you
Mhm.
really think about making sure you get a good lather and that you're really washing both the palms and the backs of your hands between all the fingers, getting your fingertips, getting around the wrists, and you're really paying attention to all of those things, it's probably going to take you 30 or 40 seconds to do that right.
Right.
So I just would say wash your hands with intention. Don't just go through the motions, and I think you'll be in good shape.
Okay.
So
And the antimicrobial soap, is that
I don't
required at
I don't think
lifestyle?
that is required. I think that's probably old data. I
Okay.
think that the latest studies on that show that it's not really any more effective than regular soap.
Mhm.
So that's probably not necessary. Whatever they
And
have in the dialysis unit, I'm sure is going to be sufficient for you to use, you know. So
sounds good. And someone asked, can you use alcohol in disinfecting your stethoscope instead of the hand disinfectant?
yeah, you can. You can use like an alcohol wipe or something
Yeah,
like that. That's
that's what
perfectly fine.
I typically do
Yeah,
for
you do not
commercial.
have to use bleach solution. Yeah, I'll do that toward the end. So I don't always, use my stethoscope for every patient every time, and if I'm going somewhat quickly, I'll sometimes use the hand sanitizer just because it's right there immediately available. But then
Yeah.
that does leave a little bit of a film on the stethoscope.
Yes.
So I will then, after a couple of rounds of that, I will go and use a proper alcohol wipe just to kind of get some of that gunk off at that point,
It
so
gets
it's
sticky
not
by the
sticky.
end. Yeah,
Yeah,
yeah.
I find the same thing with my hands. Even though, you know, even if I'm not doing something that requires hand washing, about every 4 or 5 times I use hand sanitizer, I just go to the sink and wash my hands because otherwise I find that my hands start to build up, funny film on them from the hand
Yeah,
sanitizers as
and
well
certain
that I
brands
don't
are
like.
like, really like smellier, like not in a good way, and also like much more like sticky than others. So, um, and then I think we'll take another question. What is the best way you find to effectively communicate with your technicians to remind them to keep on top of hand hygiene?
Yeah, it's just as simple as calling it out when you see it. Don't do it right in front of the patient and don't do it in front of their peers, right? So the most effective way is to pull that person aside in a quiet way and in a semi-private way and just say, hey, I just want to remind you, when you go between machines, make sure that you change your gloves and perform hand hygiene before moving on to another station. I noticed, I observed earlier that you forgot to do that with this patient over here. Do it in a subtle, way where they're not embarrassed, they're not humiliated and you're not doing it in front of the patient where the patient freaks out that someone's not following proper
Hmm.
protocols for them, right? But don't be afraid to speak up. I mean, um, I don't, most of you that are still in training probably don't yet appreciate the impact that your words have on other people and how much they really will respect the things that you say. And if you take the moment to kindly redirect, you carry a lot of weight, and the things that you say really matter to them. So don't be shy to speak up if you notice that.
Thank
Um,
you. And we'll take one last question and we'll wrap up. Can you elaborate between clean and dirty sinks?
Yeah, so to be honest, I don't know 100% what goes into a dirty sink, but I know that all clinics are required to have both clean and dirty sinks. And clean sinks are where clean activities happen. So that's where hand washing would occur. That's where you would encourage your patients to go wash their access before dialysis. I don't exactly know what dirty sinks are used for. I don't know if somebody else on the call honestly can bail me out on that one. I just know it's important that they're labeled, that it's obvious which is which. And that for things like washing hands that is only being performed in a clean sink. So
Okay. Well, that's all we have time for, but this was a fantastic presentation. Mark, thank you so much, and thank you all for attending. And we will have another session this month. And I hope you all can join us. And the registration link was put in the chat, or you can go to the forum website and you should have all the links in there, and the recording will become available once it's uploaded. So thank you all again. See you next time.
all
Bye.
right. Thanks, guys. Take care.